Thank you very much. I would like to first thank the organizing committee, selectively Dr. Al-Hattab and his group for organizing this great event. And I would like also to thank the TECIDA group for giving me this chance to present about Gaucher disease. So as a guest, some kind of stimulating the attendee, I wish to be there, but unfortunately it's not in my hand. So I would like to share with you 5 cases, and I would like you to think about all of this scenario and select in your mind which one will be the most likely to be diagnosed with the Gaucher disease. So the first scenario, this is almost 3-year-old child referred to us from our referral hospitals. And she had initially been a healthy child, had uneventful prenatal, natal, and postnatal history, admitted couples of weeks with the impression of gastroenteritis and clinically noted to have a significant abdominal distension. And that was noted also by the mom since long time. The child looks fine and stable. Second case, this is a 15-month-old admitted with recurrent chest infection, and she had extensive workup in one of the secondary hospitals. She noted to have failure to thrive, a chronic cough, and at the same time, she was found to have hepatosplenomegaly. She looks very sick with the significant pancytopenia laboratory-wise and hyperlipidemia. Third scenario, this is a 4-year-old child with a progressive history of abdominal distension noted when she was almost 2 years. And she had a borderline anemia with hemoglobin of 9 to 10, normal platelet count and normal WBC count, investigated thoroughly and no reason was found. Mentally, she was fine with a normal developmental and normal IQ. Fourth scenario, this is 29-year-old male, previously healthy, seen at the kidney transplantation clinic as a potential donor for his brother who had chronic renal failure and he was in need of the renal transplant. His ultrasound abdomen as a part of the routine screening for a donor, he found to have hepatosplenomegaly and evaluated by the hematology group, MRI done and bone marrow also. And the last one was a 48-hour-old newborn with a non-immune hydrops fetalis diagnosed antenatally. Mother was Graphida 7, Bara 7, positive history of consanguinity. He had that time almost 7 normal healthy siblings. On clinical finding, found to have subtle dysmorphism, clear cornea, normal heart sound, confirmed to have extensive hepatosplenomegaly, low hemoglobin, low platelet, normal WBC, significant ascites with a pleural effusion. So can you guess one of these cases will be finally diagnosed as Gaucher disease? Unfortunately, I cannot hear you, but I think all of you, at least most of you, will turn out to be a Gaucher disease, and that was the real scenario. So all those patients whom I am presented tend to have a confirmed Gaucher disease. So the patient might come to you with a different scenario, and unless you keep Gaucher among the different diagnoses, you might miss the patient for a long time. That will lead us to our topics for today, which is Gaucher disease. Quite sure most of you have heard about Gaucher disease. This is well-known conditions now, and the history for this disease being long time. So most of the physicians in the field of medicine, at least they heard once about Gaucher disease. But today I will try to give you more clinical scenarios about this disease, and I will take you through the journey of this disease. So we'll talk about the pathophysiology, classification of Gaucher disease, clinical manifestation, and symptoms, diagnosis, and treatment journey, and the local experience in Oman. Since this is very short, I will try to be brief in each slide. So this is well known and one of the oldest lysosomal storage disease. It had unfortunately heterogeneous presentations. It's a multisystemic disease. And usually, if untreated, this will lead to the major significant life-threatening complications. It's an autosomal recessive condition, so it might be found more in the family with the consanguinity. And it's been described, and the name of this disease came from the first pathologist who described this disease. And that pathologist named the disease with his name since almost more than 120 years back. And he was this being found in the female who had enlarged spleen and thought to have a splenic malignancy. So usually what will happen in the Gaucher disease, the usual scenario of Gaucher disease, you have a very complex molecules called the glycosphingolipids, and these molecules need to be just converted to another less complex molecule by either enzyme or by which need the help from the cofactor called cytosine C. So what usually happens in Gaucher disease, there will be a deficiency in this enzyme, glycocerebrosidase, and that will lead to the massive and accumulation of glycosylceramides. This is a complex material, will accumulate in different parts of the body tissue and will lead definitely to the sequelae and complications. Based on that, you can imagine the source of the accumulations. This is purely a macrophage kind of cell, which have this kind of enzyme. It's present in most of the tissue. So depend on the immigration of this cell, you will get the clinical manifestation. So this cell will immigrate to the spleen, so you will get a massive splenomegaly and significant thrombocytopenia, hyper status, fatigue, or you will get another clinical manifestation in terms of this accumulated in the lung with the infiltrative lung disease. Or if it is in the bone, you will get a major vascular osteonecrosis, osteopenia, sometimes even pathological fractures. And you have to give really a very critical attention to this kind of clinical manifestation, because most of the time the patient will not come with the full clinical pictures to you. He might come only with the single. So if you found unexplained fractures in somebody who used to be healthy with the borderline thrombocytopenia, you have to keep in your mind possibility. You have to give an attention to the early symptoms of the disease, so you can't be accumulate in the liver. It will be, in some of the cases, they will have a you look at how patient might present to you. So this patient, most of the time, in 90% or 80% to 90% of the patient, they will have splenomegaly. This is a quite significant finding. It might be a good clinical finding where you can guide yourself. And most of them, they will have also anemia, and some of them, they might come only with the general non-specific express the pain. A patient with possibility of Gaucher disease, take more details, see if there is any kind of unusual in avoid due to the inability. So three forms of the Gaucher disease. Type 1, which is usually have no CNS manifestations. Type 2 with the acute neuropathic. And most of you will not see type 2 in most of the cases, because type 2 usually you will be lucky to see type 2 is the neonatologist, because this kind of patient, they will have the severe form of the Gaucher disease. So they might present in the early stage. And when they presented, most of the time, they will have very complex of life. And the other types, type 3 patient also, they might not have the, and sometimes they need at least 1 decade to show you the CNS manifestation. And this is very important, crucial, important point in that terms of counseling when you face this kind of diagnosis and when you start counseling the family. Don't be that much confident unless you're being guided by some molecular finding which genotype, phenotype correlate. Otherwise, you have to be still very careful when you diagnose a patient with the type 1, unless the clinical course proving that. Or you have, as I mentioned previously, very strong genotype which direct you to label this patient finally as type 1. We had a lot of experience where we thought this is a type 1 patient, but with the time we start to see a complex scenario of the patient, which conclude this is a type 3 rather than type 1. And there is a major difference in the type 3 and type 1. So one of the good clue also to get diagnosed type 1 in this kind of patient, they will have some element of failure to thrive, might be not seen in other more complex scenarios when the people will be quite worried to miss the condition. So failure to thrive, it might be a good point where you can utilize this as a clinical clue to differentiate between the other acute kind of urgent conditions and Gaucher disease. So as I mentioned, you can see with me here in Gaucher disease, you will have a different clinical phenotype from antenatal finding as hydrops fetalis till an adult patient who might be asymptomatic. So you can think and keep in. So there is overall population prevalence of Gaucher disease, and this is well known. And overall, the incidence of Gaucher disease is between 1 to 40,000 to 1 in 60,000, and it's by ethnic. So most common it's being seen and reported Ashkenazi Jewish. And there is also from that group, we got some idea about the genotype phenotype correlations. So it's well known that this kind of mutation is quite common, and 90% of the muted allele found in the Ashkenazi Jewish. You can see here like L4B, this is one of the commonest, and also N370S, this is one of the commonest also genotype seen in patients with Gaucher disease. So this might guide you to know that L444 is more with the type 3 and the N370S with type 1. So why this disease, despite that being missed, and most of the time the patient might give you some kind of clue. The reason, maybe some people still, they thought inherited disease always presented at birth, which is not the true. And also they might also think of other differential diagnosis, which sound more serious, and they spend really very long time and they do a very extensive investigation to make sure they are not missing kind of treatable condition. So it's still missed because also it's rare and sometimes overlooked, and most of the important, it's not screened in most of this patient. Although sometimes you might be expert, but sometimes the clinical phenotype might not guide you directly. So unless you have very good screening system and you thought about that disease among the differential diagnosis, even if you are an expert, still you will miss the patient. So screening tool is one of the good tools where you can pick this patient in early stage of disease, and you will really avoid unnecessary investigation, and it will be a cost effectiveness in the terms of the treatment. So the other differential diagnosis, which most of the time hematologists are really worried about, is that serious conditions like lymphoma and also leukemia. And you can see Gaucher disease might mimic the other kind of serious conditions presentations, But most of I mentioned already in the previous 2 slides that if you look at the growth retardations and delay, puberty is quite common selectively in pediatric age group. So you might utilize this kind of clinical finding, clinical phenotype to differentiate between Gaucher disease and other serious disease. But still, you know, Gaucher disease patient still being missed for long time, more than 10 years. And by the end, it will be a progressive and it might overlooked with the other clinical manifestation. And even patient might pass away and die with the complications without a clear diagnosis. So this kind of delay will lead to the prematurity death from the bleeding complications, pulmonary hypertension, liver disease, sepsis, complication arising from advanced bone disease, and definitely there will be a major impact on the quality of life. And this is a terminology which are we using nowadays frequently, quality of life. It's seen in good group of patients who've been diagnosed to have a Gaucher disease in adult age group. When you look at them, they will be quite comfortable. They are fine. Their platelet will be borderline between 100 to 120. They are maintaining good hemoglobin, and they have borderline hepatosplenomegaly. And you will feel maybe they are still not in major need to initiate the treatment. But if you just spend a good time with this kind of patient and try to take more details of their quality of life, you will find definitely it's not totally normal. So if you initiate the treatment, you can see a big difference in the quality of life of this kind of patient. So where you should think about Gaucher disease. So in this kind of patient with the splenomegaly or thrombocytopenia, you should be tested for Gaucher disease after the following condition being ruled out. And that is quite serious, so you will not miss a very serious and treatable condition. Definitely hematological malignancy, hemolytic anemia, thalassemia, immune thrombocytopurpura, splenomegaly due to the portal hypertension. In other group, if the patient presented with the splenomegaly or thrombocytopenia should be tested for Gaucher disease when they have been diagnosed with any of the following conditions. So if the patient been already investigated and ended to have this kind of labeled diagnosis, which was clearly seen in a lot of the hematology clinic, like idiopathic splenomegaly without known cause, or idiopathic thrombocytopenia, atypical or unresponsive idiopathic thrombocytopenia, unexplained bleeding and bruising, unexplained hyperperitonemia with a normal transferrin saturation. So in this group of patients, you have to think of possibility of Gaucher disease, and you have to screen the patient for Gaucher disease. So one of the good and easy flexible tool to screen this patient, I know enzyme study, to send an enzyme study on the full blood, it's sometimes difficult because you don't have an access to that most of the time, and to have very good result, you have to send it immediately within 24 hours. That sometimes make life difficult, and it's not an easy to get it everywhere. So one of the very useful tools to screen this patient on filter paper. So you can take the filter paper, you can store that filter paper, and you can send it for the screening. And it's very simple kind of methods, a very easy procedure. You can assign one of your clinical nurse in the clinic to collect this and keep. No harm to investigate the patient for other serious differential diagnosis, but it will be, believe me, very good step to avoid unnecessary investigation future-wise if you diagnose your patient with the Gaucher disease. And one of the other important part is to apply diagnostic algorithm in practice. This is very useful and it's going to save time. And I'm going to explain that to you. So if you have a patient, please keep an attention to this diagram. So if you have a patient with the splenomegaly or hepatomegaly, and you found him to have thrombocytopenia, and there is anemia, or they might have normal hemoglobin. So if he having splenomegaly and thrombocytopenia, you will think this most likely, or there is high chance this might be a Gaucher patient, there is a possibility. You will look at the other clinical supporting find like X-ray finding, or you will look if there is any other CNS manifestation like strabism. Sometimes even developmental delay might be present in patients with the Gaucher disease, or abnormal epilomotor apraxia, growth retardations on or abnormal weight, and you will look at the serum ferritin if it's abnormal. And if all this clinical criteria presented with the radiological finding and you have hepatosplenomegaly, you will screen your patient for a Gaucher disease. So if you have at least more than 3 clinical criteria, you should think of Gaucher and you have to send the enzyme study. So the enzyme study, if confirmed the diagnosis, that's great. And you can plan your further management with the patient. And if still your enzyme study came normal, you have to think of other possibilities. And you can think of bone marrow examinations. In other scenario, if you have a patient with splenomegaly and hepatosplenomegaly with the hepatomegaly, but there is no thrombocytopenia or no anemia, you have to look for other causes of splenomegaly. If you found something, that's it. It might be something else. You confirm the diagnosis. Otherwise, you have to go back and think of possibility of Gaucher disease. So in case this patient doesn't meet the clinical criteria, but he has still splenomegaly and thrombocytopenia, sometimes it might be also useful to do a bone marrow examination, and you look for at the same time on that request of bone marrow to the histopathology, you might mention clearly that you would like to look for a Gaucher cell. So if they will give a proper attention to that, and they might guide you also in the diagnosis. So if the patient found to have signs of the hematological or oncology malignancy, that's it. He will have a appropriate treatment by the hematologist. If still no, bone marrow does not show any of the hematological condition or malignancy, and there is no other signs of other metabolic conditions, still you have to screen the patient. Anyway, this being published, and you can, I guess, put the reference of the publication, so you can guess trace this in the literature and utilize this algorithm to approach any patient with the potential possibility of Gaucher disease. It's very useful. So let's now go through the journey of the Gaucher disease. So the story of Gaucher disease started since long time. And surprisingly, it was start with the gene therapy in 1983. And then this being followed by very major advance in the technology. So the first enzyme of Gaucher disease was produced in 1990s, which was the initially oligoserase, then being renamed as imigloserase, and that being followed up after almost 10 years in 2000s by approval of substrate reduction therapy, which was amiglustat. And later on, almost every 10 years, we will have a major advance in the pathway of the Gaucher disease. So in 2010, there is a new enzyme came in the market, which is phyloglycerase. And it was one of the approval of gene activation technology based enzyme replacement therapy in US, and EU. And later on in 2014, there is another advance in the technology also, where we have another substrate reduction therapy, which is oligostate. So now I will take you through a very short study in brief. So this study was aimed to compare the safety and efficacy of the phyloglycerase in patients who already been diagnosed with Gaucher disease, and he was on treatment for more than at least 30 months. The main aim of the study was to look at the safety and efficacy, as already I mentioned. So it was called the safety switch study, where they shifted the patient from one medication to another medications. So the study duration was almost 12 months. And they selected a group of patients who been on alternative week treatment, and the dose for the patient was between 15 to 60 units per kg. As you know, all of the patients will not have a fixed dose. It depends on their clinical response and needs. So there is a major variability in the dose selected for this kind of patient, and that's a very common clinical practice. So the key inclusion criteria in this study, they select a patient diagnosed to have a Gaucher disease, receiving imiglycerase for at least 30 consecutive months without interrupt. And the dose, as I mentioned, was between 15 to 16 units per kg. And they documented this patient should have documented the stable hemoglobin concentrations within plus or minus 1 gram per deciliter of secretin value during the past 6 months, and also documented the stable platelet count plus minus 20% of the secretin value during the past 6 months for at least 6 months at the same imiglycerase dose. And the key study objective was, as I mentioned, primary objective was to look and evaluate the safety of alternative dosing of phenylglycerase alpha in patients with the Gaucher disease who received already imiglycerase. And secondary objectives was to evaluate the changes from baseline in the hemoglobin concentration, platelet count, liver, and spleen volume. Due to the shortage of time, I will not go in more details. I will give you just a brief finding from this study. So the baseline patient who been selected was almost 42 patients, 37 were, 18 were male and 22 were female, almost 40 patients. And the age group was, the median age group was 37. And there was a good number who were less than 18 years, almost 22.5%. And the clinical parameters showed the following: hemoglobin average was 13.8, platelet was 162, and spleen volume was 2.5 from the normal volume size, and the liver was 0.3. They look at their keto levels also, and the duration of the previous imiglycerase median. Some of the patients been for a long time on imiglycerase, and also at the same time, they look at the antibodies, and which is not that much significant, which is well known in most of the patients who been on imiglycerase. So they have looked at the significant adverse event in most of this patient, and they had only one adverse event to the hypersensitivity in one of the patients, where they have to discontinue the medications. No other serious severe adverse event in 12 months. And the study showed very sustained clinical stability in hematological parameters during the 12 months of phenylglycerase alpha treatment. You can see that in this graph, and you can look at the stability of hemoglobin and also the platelet count. And also it showed also very sustained stability of the visceral parameters during the 12 months. So in short, we have seen from this safety switch study, there is no major changes, and the study proved sustained clinical stability in the hepatosplenocytes in this patient in last 12 months of during the study durations, and also sustained the clinical stability in parameters like hemoglobin and platelet. So now I will move to the local experience. So I was just trying to search online the literatures if we have a good input in this area from the Arab countries. And unfortunately, I found only very few reports, and most of the time the reports were as a case report. And I can believe and strongly that this might be either to the underdiagnosed selectively type 1 with the late onset. And also at the same time, maybe it needs some kind of collaborative effort from the all Middle East country to report this patient, because I'm quite sure we do have a good numbers of patients who've been on treatment and they showed also good response. So it's an effort matter, and I wish that will happen in future. So if we look at our local experience, to alert you, here in Oman, we have two major centers who are taking care of metabolic patients, mainly SQ hospitals, Sultan Qaboos University hospitals, and Royal Hospital, which is the main government hospitals in country. So I will show you our patient are Royal Hospitals. So currently we have 6 patients with a different age group, as you can see here in this table, from 2 years up to 29 years. Most of this patient had very classical phenotype of Gaucher disease. Despite that, as I mentioned in the previous scenarios, most of them, they took long time till they been diagnosed. And as I mentioned in one of the slides, splenomegaly considered one of the most important clinical phenotype, which can be direct you to the screening of Gaucher disease, which was found in most of our patients. And also in pediatric age group selectively, failure to thrive might be a good clue. And as we are aware, most of these patients, they will have normal IQ. And initially, some of them had no CNS manifestation, but later on, 2 of them tend to start some CNS manifestation. So they've been labeled as type 3. And this one of our treated patient, case 2, who presented from the Sur hospital with a significant history of recurrent infection. She been labeled as potentially possible immunodeficiency. She had a significant failure to thrive and hepatosplenomegaly with abnormal chest X-ray finding, labeled as questionable severe lung infiltration, possible severe form of asthma. And she been referred as a case of potentially HLH initially. Her bone marrow showed Gaucher cell, and she was diagnosed to have Gaucher cell type 1. Started on treatment, and you cannot imagine the difference in the phenotype. This is her pictures after the enzyme replacement therapy. And this is the case 3, who was roaming for a long time locally and outside the country with extensive hepatosplenomegaly, which was really something alerting the family and destroy their life on daily basis, because the child, she cannot go outside. Her tummy was quite big, and she been pointed that she's having abnormal tummy. She go back to home crying, and mother, she was looking for help to know what's going on. She had multiple investigation, liver biopsy, and no conclusion, potentially questionable lipid storage disease. But the enzyme study was not helping anyway. Sometimes you might get kind of these cases, depend on the quality of the enzyme, the way enzyme was sent, the kind of storage and temperature effect. So you might miss the case. So this is a learning case. Still, if you have strong suspicion of Gaucher disease in this kind of patient, I think still you have to go for a molecular diagnosis. So this patient was diagnosed by a molecular study. And at the same time, I mentioned to you, we have 2 kinds of deficiency. So the deficiency might be in the enzyme itself, or it might be in the cofactors. So if you have the clinical suspicion of Gaucher disease, you think this patient is meeting the criteria of Gaucher disease, you've been supported by radiological finding and sometimes even by the bone marrow, and your enzyme study was normal. You did the molecular for the enzymes, for the gene, and it was negative. You have to think of other possibility, which is sabotine C deficiency. So sabotine C deficiency patient, they mimic classical presentation of patient with the Gaucher disease. It's a Gaucher disease, but due to the cofactor deficiency. So this is my conclusion. Gaucher disease is most common lysosomal storage disease. We are quite happy because nowadays in this disease, we have more than 1 methods to treat the patient. There is a lot of the good work being done in this kind of disease. Now you can handle the patient in different way by more than 1 type of the enzyme. Also, you have substrate reduction. So a major effort being done in this disease. We have very good clinical experience in treating this patient. We have seen the course of disease where the patient being symptomatic, then being on treatment. We have seen a patient being treated on more than 20 years and they have very normal quality of life. So it's deserved to be screened and to be just looked for in any patient with the potential clinical phenotype. And this disease might still exist in the community with a high rate of consanguinity, as it's an autosomal recessive disorder. And it might be still underdiagnosed because, as I mentioned to you, patient will not come with the full clinical phenotype. He might just present it to you with a single phenotype, which might be bone pain, and maybe even miss some of the patients. They might come also, they are not feeling comfortable, they cannot just play football as the others. So take this kind of patient symptoms seriously and think what's going wrong. Simple investigation like CBC might guide you to think if you found borderline thrombocytopenia. Don't wait for your patient to give you a full clinical phenotype. Screen him with the high suspicion. You can do a lot of different. A lot of patients, they had more than 3 times bone marrow aspiration. You can imagine 3 times bone marrow aspiration for non-specific thrombocytopenia, and they turned later to have Gaucher disease. And definitely, there might be a founder mutation where you can use. And as I mentioned, you can be supported by some genotype-phenotype correlation to give a proper counseling in Gaucher disease. This is my last slide. Thank you very much.